Had a quiet day in surgery last week and we had a patient cancel. So I took the opportunity to get the nerve stimulator out just to do a little quick tibial nerve anatomy teaching video. Here's the setup. I'm going to use a peripheral nerve stimulator to locate the tibial nerve behind the medial malleolus. The peripheral nerve stimulator is the box you see in the centre bottom of the picture, and it connects via an electrode to the patient. You can see the electrode here is on the left calf. We'll do it under skin prep. You can see in the centre left of the picture there's some chloroprep, and the pole needle that we use to locate the nerve is in the centre of the picture. So the small battery in the peripheral nerve stimulator sends a few little impulses down the needle, and that will make a nerve fire, and depending on which muscles twitch, it will show you exactly where the needle is. And it being a needle, you can then inject through the needle to knock out the nerve as a peripheral block. So I've already marked up posterior tibial artery, which is coming down, comes into the foot. If we're thinking about our locating the tibial nerve, tip of the medial malleolus, and if you think about the point of the heel, and I normally take a line between the two, and then the entry point for the needle is going to be just underneath. We're going to aim to be posterior, lateral to the artery. Just going to just do a bit of skin prep with these chloropreps. They're quite orangey. At least you know where the skin prep has been. Let's get some gauze, which of course is not knocking about. That looks pretty okay, so let's put our machine on, and we're going to set it up at about 5 millivolts to start with. There's our little needle, so we've got a whole needle. I'm just going to come in, just so I'm not in the way of myself, Nick, I'm just going to come into there. Alrighty, little scratch, 3, 2, 1, scratch. So let me just see, that's twitching away. You can see the toe is twitching, but on 5 milliamps that's pretty easy really, because it's put in a big old dose. So what we really want to do is come down. You see that twitching, and the idea is you'd come down to inject to actually about 0.5. I don't know if you can see that through my fat hands, and then you just basically want to come right on the nerve. Just want to see. And then for a real patient, you'd get the needle right on the nerve. You'd get the milliamps down to about 0.5, so you know that with the smallest voltage possible, you're right on the nerve, and at that point you can inject. Here's a picture from an anatomy course that I was running last year. We've dissected out this left foot in the posterior medial compartment, and we're taking the skin off. And just so you can see, we've started out to dissect through tibialis posterior tendon in between the black brackets there. Before we took the skin off, we put a few bits of red dye in. I was trying to demonstrate to my students where we could do different injections for the tibial nerve and also for plantar fasciitis. This particular red dot is where I would normally go in to try and block the tibial nerve, and then what we did after this was dissect off the retinacula to show where the injectate of the dye had gone. Unfortunately, at this point, the camera would have got a little bit messy with the formaldehyde and the juice. But just to give you an idea though of the local anatomy.